My name is Megan Fisher, and today is November 30th, 2020. So, beginning with case 3, based on the child's symptoms, including drowsiness, persistent thirst, and frequent urination, it would already be expected that type 1 diabetes should be explored as a possibility. Because of the low serum insulin levels, the most likely diagnosis is certainly type 1 diabetes, also termed diabetes mellitus. Type 1 diabetes is an autoimmune disorder that involves an attack of the immune system on the pancreatic islet cells, which produce insulin. Because many of the pancreatic islet cells are destroyed, the patient experiences low insulin levels. Insulin is an important hormone that regulates glucose uptake by the cells. According to Harper's Illustrated Biochemistry, glucose uptake into muscle and adipose tissue is controlled by insulin, which is secreted by the beta islet cells of the pancreas in response to an increased concentration of glucose in the portal blood. Without insulin present, blood glucose levels can become dangerously high. Meanwhile, tissues are starved for glucose. According to The Lancet, diagnosis of diabetes has historically included fasting blood glucose higher than 7 micromoles per liter. Any blood glucose of 11 to 1 micromoles per liter or higher with symptoms of hyperglycemia or an abnormal 2H oral glucose tolerance test. Therefore, I would expect the patient's fasting blood glucose levels to be above the normal range, given his current condition. There are several enzymes at play in glucose regulation. Therefore, many enzymes are impacted by type 1 diabetes. Among these enzymes are adenylate cyclase and protein kinase A. To begin understanding these two enzymes, one must consider the role of cyclic AMP in type 1 diabetes. Cyclic AMP is a messenger that helps to regulate healthy glucose levels, and it is activated by adenylate cyclase and cleaved by phosphodiesterase. The presence of adenylate cyclase is dependent on the release of epinephrine and glucagon, whereas phosphodiesterase is dependent on the release of insulin. This system typically operates effectively as the balance of glucagon, epinephrine, and insulin leads to stable glucose levels by activating and inhibiting cyclic AMP as needed. However, in a patient with type 1 diabetes, there is a lack of insulin present, meaning that phosphodiesterase is not present to cleave cyclic AMP, leading to an overload of cyclic AMP. As the European Journal of Biochemistry explains, the effects of glucagon on liver metabolism could be mimicked by high concentrations of cyclic AMP. Insulin, on the other hand, was shown to reduce the increased levels of the cyclic nucleotide in liver, and acute insulin deficiency led to a rise in cyclic AMP concentrations. From these studies, one could assume an effect of insulin upon enzymes controlling formation or breakdown of cyclic AMP. The presence of cyclic AMP leads to the second major enzyme involved in type 1 diabetes, which is protein kinase A. When high levels of cyclic AMP are present, as seen with type 1 diabetes, protein kinase A is activated. This enzyme plays an important role in glucose regulation, as the AMP-activated protein kinase is the master regulator of energy homeostasis in eukaryotic cells. AMPK is also involved in the regulation of whole body energy metabolism and responds to hormonal and nutritional signals in the central nervous system and peripheral tissues that control food intake and energy expenditure. Protein kinase A leads to the phosphorylation of phosphofructokinase 2, fructose 2,6-bisphosphatase, which inhibits glycolysis and activates gluconeogenesis. In other words, glucose is not stored as glycogen, and even more glucose is released. This cascade of events involving adenylate cyclase and protein kinase A creates a dangerous situation where large amounts of glucose are circulating in the blood. However, the tissues are starved for glucose due to a lack of insulin. What may occur next is the breakdown of triacylglycerols and protein degradation. In conclusion, the child's symptoms certainly align with a diagnosis of type 1 diabetes. Moving on to case 4. In order to understand the infant's condition, one must first review her symptoms holistically. The infant is displaying jitters and hypoglycemia after 2 hours of fasting. However, her blood glucose levels increase immediately after feeding. This indicates that she is able to break down and utilize breast milk as fuel in the fed state, yet she cannot use glycogen storage as fuel in the fasting state. When epinephrine is administered, there is an increase in the infant's blood lactate levels, most likely due to glycogenolysis occurring in the skeletal muscle tissue, as well as an increase in glycolytic activity. The infant exhibits an enlarged liver, which is commonly associated with a buildup of glycogen. Therefore, after examining the patient's symptoms collectively, the most likely diagnosis is glycogen storage disease, specifically von Gurk disease, which is the inability to use glycogen. Von Gurk disease is caused by a deficiency of the enzyme glucose 6-phosphatase. According to Harper's Illustrated Biochemistry, in liver but not muscle, glucose 6-phosphatase catalyzes hydrolysis of glucose 6-phosphate, yielding glucose that is exported, leading to an increase in the blood glucose concentration. Therefore, it would make sense that a patient with von Gurk disease would experience low blood glucose levels after fasting because they lack the enzyme required to break down glycogen as fuel. As for the increase in lactate levels following epinephrine administration, this is a common diagnostic feature of von Gurk disease. As the Journal of Clinical Investigation explains, the clinical test most commonly employed in the diagnosis of hepatic glycogen disease consists of observation of the blood glucose response to injection of epinephrine or glucagon. Normal children or adults respond to these agents with a prompt elevation of the blood glucose level. Patients with liver glycogen disease, on the other hand, show no response or only small and delayed increases in blood glucose concentration. The principal end product of hepatic glycogenolysis appeared to be lactate rather than glucose. It seems then that the combination of symptoms indicates glycogen storage disease. It is unlikely that the patient has hereditary fructose intolerance because the infant is not receiving any fructose in the diet as she is breastfeeding. According to Harper's Illustrated Biochemistry, the absence of aldolase B, which cleaves fructose 1-phosphate, leads to hereditary fructose intolerance, which is characterized by profound hypoglycemia and vomiting after consumption of fructose. The patient's symptoms could not be in response to fructose because she is not ingesting fructose. The diagnosis of galactosemia is also unlikely because the infant's symptoms are associated with periods of fasting rather than feeding. Furthermore, her symptoms did not appear for the first 2 months of her life, although she has been breastfeeding since birth. According to Smart Engage, people with galactosemia are unable to fully break down the simple sugar galactose. Galactose makes up 1/2 of lactose, the sugar found in milk. If an infant with galactosemia is given milk, substances made from galactose build up in the infant's system. These substances damage the liver, brain, kidneys, and eyes. Lastly, a diagnosis of glucose 6-phosphate dehydrogenase deficiency does not fit the symptoms described because the infant is not experiencing anemia. According to the American Journal of Hematology, G6PD deficiency, or glucose 6-phosphate dehydrogenase deficiency, is an X-linked disease that affects 400 million people worldwide. During a period of oxidative stress, intracellular levels of the reduced form of the nicotinamide adenine dinucleotide phosphate, NADPH, in these patients are depleted. This leads to the accumulation of oxidative damaged proteins and lipids in their red blood cells, resulting in hemolysis of deficient red blood cells. In conclusion, glycogen storage disease is certainly the most likely diagnosis given the patient's symptoms. Thank you.